بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله أجمعين. I don't think I'm expert because I did this talk twice. He's laughing, Walid. Just I'm disorganized, I guess, with my scheduling and things like that. So what the task that I'm actually asked to do today is to talk about pulmonary hypertension in heart failure. And I think pulmonary hypertension in heart failure is like the PVCs. We tend to ignore it. And maybe it has important implications. So if you look at the pulmonary hypertension, left heart disease, in fact, actually, it's the most common cause of pulmonary hypertension. It accounts for about 65 to 80% of all patients with pulmonary hypertension. And heart failure basically constitutes the most of these cases. And we know that heart failure is very prevalent, with more than 4.9 million in United States of 2001, and more than almost 400 cases, incidental cases every year. And now there's different definitions of pulmonary hypertension if you look at the echocardiographic kind of literature, but we know that pulmonary hypertension is basically a hemodynamic abnormality, so the definition should be hemodynamic. And we define pulmonary hypertension, left heart disease, as a sustained increase in mean pulmonary arterial pressure of at least 25 millimeters of mercury, with increased left ventricular filling pressures, defined as increase in pulmonary arterial wedge pressure of at least more than 15 millimeters. And this group constitutes group 2 in, according to WHO classification of pulmonary hypertension. Now, the hemodynamic classification goes even further. We refine, our classification of pH, or pulmonary hypertension, left heart disease, according to whether they have increased transpulmonary gradients. Specifically now, with the newer definition, is the use of diastolic pulmonary gradient rather than transpulmonary gradient, utilizing the difference between the diastolic pressure and the mean wedge pressure. So if you have a normal diastolic gradient, in normal people usually it's about 1 to 3, but it's in people with heart disease, it's accepted up to 5. And the cutoff was used is less than 7. Basically, 6 or less is normal. And when you have a PVR of less than 3 Wood units or less, that basically constitutes normal transpulmonary gradient or diastolic pulmonary gradient. And this patient population, we call them that they have isolated post-capillary hypertension. On the other hand, people that they have increased diastolic gradient or increased PVR, these patients constitute what we call combined post-capillary and pre-capillary hypertension, and also you can subdivide them into 2 groups based on whether they respond to vasodilator challenge or not. Pathophysiologically, we know that all it starts from the LV, increase in basically filling pressures, LA, loss of LA compliance, loss of or reduced LA contraction, that basically causes back pressure on the pulmonary venous vasculature, and eventually with basically, if it continues for a long time with advent of vasoconstriction, vascular remodeling, you get basically of fixed increase in pulmonary vascular resistance and fixed pulmonary hypertension. That leads to basically right ventricular hypertrophy, dilatation, and right ventricular failure. Now, if you look histologically, this is from a paper from Georges et al. From Vienna, and basically they looked at a very large patient population with pulmonary hypertension due to left heart disease, and they have some autopsies from these patients. And if you look at the group with normal transpulmonary gradient, means less than 12, this patient, it happened that his transpulmonary gradient was 3 millimeters, and you can see that basically there is normal wall of the pulmonary arteries. On the other hand, if you look at the patients that they have transpulmonary gradient, increase in transpulmonary gradient above 12 millimeter mercury, but normal diastolic pulmonary gradient of less than 7, they have some increase in the medial thickness, but it's not profound. Furthermore, if you look at the patient, for example, this patient has increase in transpulmonary gradient and increase in diastolic gradient, and they have significant medial hypertrophy. And this is a patient with idiopathic pulmonary hypertension. They have more severe vasculopathy. Now, if you look at the percentage or the number of patients that they have these changes, you can see that there's a gradient from the normal transpulmonary gradient to increased transpulmonary gradient with normal diastolic gradient to people with both increase in transpulmonary gradient and diastolic gradient. And this basically forms a more severe constitutes a more severe phenotype in terms of pulmonary vasculopathy. These people actually, they showed that this patient group had the worst prognosis in comparison, worse prognosis in comparison with these two groups, and in comparison, of course, with people with no pulmonary hypertension. In terms of the prevalence, it's variable. It depends on which patient population you study. It depends on what type of heart failure, whether it's HFrEF or HFpEF, and also depends on method of assessment, as well as the cutoff used, especially when it comes to echocardiography. And it ranges from about 36% to over 80% in HFpEF, and about from 40 to 75% in HFrEF. This is a very common disease that we tend to ignore, unfortunately. And this is from the Olmsted County study from Mayo Clinic group, and they looked at a group of over 700 patients with hypertension and over 200 patients with HFpEF. And you can see that the incidence is really very high in this patient group of 83%. They used a cutoff, an echo cutoff of RVSP of 35 millimeters of mercury, a little bit kind of a lower threshold in terms of diagnosing pulmonary hypertension. Now, if you look, this is a study, a CAT-based study, not an echo-based study. And again, in this patient of 455 patients, the prevalence was really very high. Over 50%. And the predictors of pulmonary hypertension in this group was actually obesity, old age, COPD, shortness of breath on exertion, and atrial fibrillation or atrial arrhythmias. Now, another study, this is the TOBCAT trial, which tested the aldosterone antagonist in HFpEF, and they used a little bit of also kind of a modest, cutoff of TR-jet of 2.9 meters per second, which translates to about maybe 36 millimeters of mercury. And the prevalence in this trial was 36%. Again, this is a large study from our group, the HEARTS trial, of about 2,609 patients. Missing data is in a significant number, about almost 500 patients that did not report pulmonary hypertension. The pulmonary hypertension defined as systolic pulmonary arterial pressure of more than 40 millimeters, and in our patient population, the prevalence was 34% in both. I mean, this is combined HFrEF and HFpEF. Now, does it mean anything if you have a patient with increased pulmonary hypertension? I mean, with pulmonary increased PE pressure, does it predict outcome or not? And several studies actually looked at this. This is, again, from the Olmsted County, the Mayo group. They looked at over 1,000 patients, and basically they divided the median PE pressure in this patient population that combines both, HFpEF and HFrEF was 48 millimeters of mercury. But when they divided their patient population into tertiles, there is a gradient in terms of mortality with the more severe pulmonary hypertension, the worse outcome. In terms of now, pulmonary hypertension does it come by itself or not? As I mentioned in pathophysiology, usually it leads to right ventricular hypertrophy and dysfunction and right ventricular failure. So is there a relation between pulmonary hypertension and RV dysfunction? Yes. A number of studies looked actually at the relation between PA pressure and RV dysfunction, either measured by TAPSE or by, for example, in this study from Mayo Clinic, right ventricular fraction shortening. And you can see that there's significant correlation between the PA pressure and the RV function. Similarly, if you use RV fractional area change, there's significant change. One interesting thing in this study, they have also a control group that they don't have underlying heart disease, and you can see that the inclination or of the regression line in the control group is flatter than in people with heart failure. And that this actually indicates, I mean, you expect that they should be actually in line with one another if it's a continuum. And that basically tells you that the RV function is very sensitive to afterload. It's not just, and also it indicates that the RV has lower contractility in these patients. So that study was done in HFpEF. The study was done in HFrEF from an Italian group from Bavia, the Stefano Ghiu's group. And again, they showed significant correlation between PA pressure and RV function in both ischemic and non-ischemic cardiomyopathy. Now, the prevalence of RV dysfunction is also variable. And again, it depends on what method you use. It tends to be the prevalence higher if you use the tricuspid annular velocity, and it tends to be lower if you use the right ventricular area change, but it ranges between 13% to 65%. And it's common in both HFrEF and HFpEF. Now, RV dysfunction, does it portend increase in mortality? Yes. This study from Dami et al., it showed from England, more than 1,500 patients with HFrEF and HFpEF, and they followed up the patient for median of 63 months, intra-quartile range of 41 to 75 months. And the mortality rate in this patient group was 36%. TABC was independent predictor of mortality in both groups. And TABC, by the way, is the tricuspid annular plane systolic excursion, which is the change in the movement of the tricuspid annulus during systole and diastole. And the best cutoff from the RSO curves came to be 15.9 millimeters, which is just less than the cutoff of normal RV function according to the American Society of Echocardiography of 16 millimeters. And interestingly, the prevalence was high in this patient group. Again, this is from the Olmsted County group from Mayo Clinic. They looked at both TABC as well the semi-quantitative visual assessment. This is a kind of the most crude way of assessing RV. And in both, actually, you can see that people with lower tertile in terms of TABC or people with even mild RV dysfunction, or mild to moderate, they have abnormal or worse outcome. This is in HFpEF. This was in HFpEF as well. And this one, based on invasive assessment of pulmonary pressure and RV function, and you can see that there is significant reduction in survival in patients with impaired RV function. Now, this study was one of the earliest studies actually looking at TABC from the Stefano Ghiu group in Pavia, and they looked at 140 patients with HFrEF, and you can see that cutoff of 14 millimeters really discriminates between patients that they have better survival and patients that they have worse survival. The same group published another paper looking at actually combination of presence of pulmonary hypertension, RV dysfunction, either separate or in combination. And you can see that the group with pulmonary hypertension and RV dysfunction defined as change in area change of less than 35% have worse prognosis. The same group also published just recently another paper looking at the combination of TABC rather than area change of 14 millimeters and systolic arterial pressure of 40 millimeters or more in people with HFrEF. And again, they showed the same kind of trend where patients with combined pulmonary hypertension and RV dysfunction have worse prognosis. Data in acute decompensated heart failure is very scarce. There's only a couple of published studies. One study, this is from Denmark, part of the ECOS trial. They enrolled 817 patients. And they assessed RV by TABC and median follow-up of 4.1 years. In this study, they showed that TABC and COPD were associated with decreased survival. And the reason why they looked at COPD because of collinearity. I mean, COPD patients usually they're going to have copulmonal, so they looked at both. But both of them were independent predictors of outcome. And this is the survival curves from that study. We looked at the heart registry patients, and we showed the same effect in acute decompensated heart failure with significant survival, mortality in patients with right ventricular dysfunction, assessed by visual assessment, not by TAPSE, not by any other sophisticated modalities. Just this is as reported by the cardiologist who is looking after the patient. And this is a relatively large study, over 2,000 patients. Now, if we looked at whether this effect is same or different. If you look at HFrEF and HFpEF, and we saw the same. Basically, both groups have worse survival if they have associated right ventricular dysfunction. And again, we looked at the interaction with pulmonary hypertension, and the group that has pulmonary hypertension and RV dysfunction, they have the worst survival. In a meta-analysis of 11 studies of over 4,000 patients, Iglesias showed that actually RV dysfunction was associated with overall mortality and admission for heart failure. The question is whether can we alter this? Can we treat this? Can we change the prognosis of patients with RV dysfunction and pulmonary hypertension with treatment? And it seems at the moment the best treatment modality is actually treating the left heart disease with decongestant, diuretics, VAD. Mitral valve repair, especially with the CLIP, have been shown to reduce pulmonary hypertension and improve symptoms in these patients. Implantable hemodynamic monitoring is shown to actually, in this patient population, to reduce hospitalization. And in this study population, those patients with pulmonary hypertension, there's a trend of reduced composite endpoint of mortality and hospitalization. In the BEST trial, actually, if you look at the beta blocker, this study was the only study among all clinical trials with beta blockers showed that actually beta blocker, in fact, may be associated with worse outcome in patients with right ventricular dysfunction. Now, can we use targeted therapy to improve prognosis in these patients? There are basically three groups of drugs: the endothelium pathway, we have the nitric oxide pathway, and the prostacyclin pathway. And if everyone remembers this trial with the first trial using IV epoprostenol that was published in the 1990s, which basically was prematurely terminated because of increased mortality in patients with heart failure. Of course, these patients were not stratified according to pulmonary hypertension. Trials with endothelium receptor inhibitors in heart failure with reduced ejection fraction were also negative. Now, there are some studies with sildenafil, few small studies that showed improvement in clinical symptoms and hemodynamic parameters. And a meta-analysis of 6 of these trials showed improvement in exercise capacity, symptoms, and reduced hospitalization. However, a recent trial that was just published in European Heart Journal looked at 52 patients randomly studied for 12 weeks, and this study failed to meet its endpoint, which is change in PA pressure. Even the secondary endpoints of reduction in pulmonary capillary wedge pressure or increase in cardiac output of VO2 were not met, and there was so this study was negative. RELAX trial, everybody remembers this trial from the Mayo group that was published in JAMA, randomized 216 patients. They looked at peak VO2 change with sildenafil, and this basically trial was negative, and the treatment group was associated with worsening renal function and more increased uric acid, proBNP, and endothelin. Riociguat, 2 studies, which is a soluble guanylate cyclase stimulator. The left trial was published in Circulation 2013 with 201 patients, also failed to show reduction in PA pressure. There's some increase in other parameters and also in symptoms. This was in HFrEF patients. And Dilate was just recently published from the same group in HFpEF and shows no improvement. There are some ongoing trials. Tadalafil, which is a pitch heart failure, was terminated. Unfortunately, we don't know why. There's 2 studies with vericiguat in HFrEF and HFpEF, the Socrates 1 and 2. There's a Melody trial with macitentan, which is a newer endothelium receptor antagonist. There's another 2 studies with ambrisentan and bosentan are ongoing. And there's some other small studies. So in conclusion, heart failure is the most common cause of pulmonary hypertension. Pulmonary hypertension and RV dysfunction are prevalent in both types of heart failure, but there's no effective therapy. Sildenafil may have potential beneficial effects in heart failure associated with the PH, but we need larger randomized clinical trials with definitive endpoints and with longer follow-up in order for us to answer this question. Thank you very much.